Hello, and thank you for the opportunity to present at the AAC 2020 conference. My name is Juliet Goldbart, and I work at Manchester Metropolitan University in the UK. Here's a brief overview of the topics that I intend to cover. But I want to start off with a point of principle, and that is that communication is a human right. This position is supported by a wide diversity of stakeholders, but many people with profound intellectual disabilities and others who would benefit from AAC have not been able to exercise this right because they've not had the opportunity to develop or use their communication skills. In today's presentation, I want to explore aspects of communication in people with profound ID with a view to facilitating their engagement with this human right, with facilitating their access to communication. So who are children and adults with profound intellectual disability? I'm going to shorten that to profound ID. As you might expect, the key characteristic is very, very severely delayed cognitive development. And it's usually described as either untestable, or if you could test it, in adults they'd be functioning below a 2-year level, well below a 2-year level. And in children, DSM-4 talks about an IQ below 20. With this level of cognitive impairment, there's increased likelihood of a range of additional disabilities and challenges. For example, visual impairment and hearing impairment, severe motor impairments, little or no comprehension of speech, and communication which is at a pre- or proto-symbolic level. Children and adults with profound ID tend to experience multiple health problems, and that frequently includes epilepsy and gastroesophageal reflex disorder, with a high proportion being non-orally fed, at least in the UK. They experience fluctuating levels of arousal or alertness, and for some, increased sleep during or disrupted sleep routines. And this may relate to medication, or it may relate to the brain damage that they have experienced. As a result of these various factors, it's not surprising then that many children and adults with profound ID experience chronic pain. In England, the majority of children with profound ID attend specialist schools, and only a minority are in inclusive schools, and some of those will be in specialist units within the inclusive school. I thought it might also be helpful in the context of this conference to say a little bit about AAC services in England. We operate what's described as a hub and spoke model, with around 12 centrally commissioned, centrally funded specialist hubs across England. And they have strong multidisciplinary teams and central funding to cover their staffing, but also to cover the costs of AAC equipment. But their brief is to provide services for that very small proportion, the 0.05% of the population, with the highest level of need, the greatest complexity of need, although, as I'll explain in a minute, that comes with certain restrictions. They also have a brief to provide training, information, and resources much more widely. Now, The remainder of the potential client group for AAC, and we calculate that to be up to around 0.5% of the population, are managed by the more locally funded, relatively generic speech and language therapists who work from clinics or schools or trusts in more local areas. However, they can refer complex clients to the central hub and receive support, assessment, guidance, equipment, and then those children or adults are then managed locally. So a central hub, and then local spokes who deliver the majority of services. As you might expect, there is a set of criteria to determine who gets a specialist service. And to access this specialist service, you need to have a severe or complex communication difficulty, and that typically is associated with a range of other challenges. You need to demonstrate a clear difference between your level of understanding, which would assume to be higher, and your ability to speak. You need to be able to show that you can understand the purpose of a communication aid, why you would have a communication aid, and then not surprisingly, that implies that you've developed well beyond cause and effect understanding. You may have experience of using low light tech AAC and really outgrown it, so demonstrated that form of technology is not sufficient for you to realize your full communication potential. And priority is given to people with conditions that are rapidly deteriorating, so conditions like motor neurone disease. Now, there are also exclusion criteria, which are highly relevant to my topic today, because you are excluded from specialist services if you haven't yet achieved understanding of the relationship between cause and effect, and if your communication skills are still at a pre-verbal level. Continuing this theme of inclusivity, I'd like us to think about communication in a way that is helpful for this client group. So a traditional model of communication would be that I, as a sender, formulate a message in my brain. I put it into a form that can be sent, for example, in speech, writing, signing, and I send that communication to you as a receiver. You hear it, you decode it, and you understand it, and hopefully act on it. But that model of communication rather excludes people who are at an early pre-verbal level. So I'm going to ask that we use Bunning's definition, which is that communication is about two or more people working together and coordinating their actions on an ongoing response to each other and to the context. And further, the guidance from ASHA, the American Speech and Hearing Association, that communication may be intentional or unintentional. It may involve conventional or unconventional signals. It may take linguistic or non-linguistic forms, and it may occur through spoken or other modes. And I think that definition will be very familiar to many of you working in AAC. Now, these definitions have considerable advantages, and the first of these is that all adults and children must be considered to be communicators. Sorry. Second, that the role of sender and receiver become very blurred because communication has become a joint effort and messages can be co-constructed by two or more communication partners. And then finally, the importance of the communication context is recognised. I'd like us now to consider the development of early communication. So I'm going to look at communication in the first 12 months of life. Now, in doing this, I'm not trying to argue that somebody with a profound ID, perhaps an 18-year-old with profound intellectual disabilities, is somehow like a baby, a 6-month-old. Our 18-year-old, although they have profound ID, will have 18 years of social experience. Our 6-month-old has only very limited, a short amount of social experience. But at 6 months, our infant is probably learning faster than they will at any time in their life, whereas our 18-year-old with profound ID, by definition, has been learning very slowly. So they're not the same thing, but I would argue that by recognising and valuing the small steps that infants go through as they progress during that first year to becoming communicators, independent, autonomous, effective communicators, we will identify steps and strategies that may be of use to learners who are going through these steps much more slowly or may have become stuck. I'd like you to have a look at the right and the left-hand sides of the screen, because on the right-hand side, I've focused on cognitive aspects and on the left on social aspects. So on the right, we're looking about acquiring world knowledge, finding out about the world, and on the other side, more about finding out about people. So starting off on the right, early actions on objects. We know that infants interact with objects in rather consistent and predictable ways. They hold things, they look at them, and they explore them with their mouths. So these are undifferentiated actions on the objects. Whereas by 6 months of age, infants are exploring objects in ways that show that they understand a little bit about their properties. So things that are interesting to bang are banged. Things that can be shaken, like a set of keys, can be shaken. Something that's nice to crumple in your hands can be crumpled. Something like cotton wool can be pulled apart and shredded. So babies are showing differentiated actions on objects which demonstrate that they've already learned something about their world. Over this same period of time, caregivers interact with babies in, again, quite predictable ways, so that in the very first few months of the baby's life, we accept a wide range of behaviours that the baby engages in as meaningful. So maybe we'll put our baby on the floor on a rug, and we'll bend over and we'll tickle its tummy. You are a gorgeous little boy, aren't you? What a lovely little boy you are. And then we stop, we wait for the baby to do something, to kick their legs, wave their arms, to blink, and we treat that as the baby's turn in conversation, and we carry on a bit more. I know, you are Daddy's beautiful one, you are. So that we're teaching the baby right from this very early stage that communication happens in this turn-taking way. So unlike what I'm doing this morning, which is a very bizarre form of communication, in normal communication, we take turns. I do a bit, you do a bit, I do a bit, and so on. Now, by about 6 months, caregivers change in their response to the baby. And I think this is very interesting, and I think that it must be a response to a change in the baby's behaviour. Because Gibb Harding tells us that from around 6 months, caregivers focus in on only certain aspects of the baby's behaviour. So they attend to baby's facial expression, the direction of their gaze, their hand movements and the sounds that they make, and they disregard other behaviours as not meaningful. Now, what is it that seems to have happened at that point in terms of the baby's behaviour? And I'm going to suggest that it's the beginnings of contingency awareness and intentionality. Contingency awareness is the earliest association that the baby makes between two events in the environment. So the relationship between a particular cause or action and some kind of effect. That might be, for example, the door opening and mother arriving. Remember that in England, this level is required for accessing specialist AAC services. This very basic association between cause and effect leads to intentionality, which is the realization that you can have an effect on the environment. It's not simply that two events are associated in time or in a causal relationship. It's that you can make things happen and how you can make things happen. In typical infants, in an ordinary everyday environment, this is achieved between 4 and 6 months, presumably as a result of repeated chance experiences. So the baby lying in a cot kicks their legs, and the mobile that you've carefully positioned above the baby's face moves up and down. And over a period of days or weeks, the baby comes to realise that when they kick their legs, the mobile moves. They can make the mobile happen. Or the baby sitting in a pushchair swings its arm and makes those yellow plastic ducks that you've strung across the front of the pushchair roll around and rattle. Again, the baby comes to realise that they can make things happen. Now, in experimental conditions, O'Brien and Watson have shown that this can be learned as early as 2 months of age, but that seems to require the immediate consequence, the immediate feedback that you get through a research study and isn't likely to happen in everyday, ordinary life. So we're looking to this happening between 4 and 6 months of age. And I'm going to argue that this is the most important thing that you will ever learn. Why? Because if you don't acquire intentionality, you never develop a realization that you can have an effect on the world, that you can make things happen. And if you never realize that you can make things happen, you engage less and less with objects and with people. Now, all of us require a certain level of stimulation or arousal to keep us from drifting off to sleep. Or we experience sensory deprivation. If I drone on, and it becomes very tiring watching this screen, and it becomes very boring, you could fall asleep after all, nobody would notice. But if you wanted to stay awake, you would engage in some form of polite and socially acceptable self-stimulatory behaviour. You might get out a packet of mint sweets and suck one of them. You might take off your rings and twirl them around on your fingers, or write yourself a note. Because you have ways of acting on the external world that raise your arousal level. Many of the children and adults that we work with who have profound intellectual disability, who haven't learned to act on the external world, have only their own bodies to engage with. And we can use an explanation from Piaget for this, really, that they are still in the stage of first habits. So babies regulate their arousal by, for example, sucking their thumbs. But for people who are stuck at this very early stage, they habituate to the stimulation that comes from activities like thumb sucking, and they become insufficient to keep their arousal level up, and so they may turn to thumb biting, which provides much more stimulation. We know that typical babies engage in activities like hair twirling. When you habituate to hair twirling, that could easily become hair pulling. So we can understand some of this self-stimulatory behavior that has the potential to be self-injurious by understanding these people as not having developed intentionality. They have no awareness that they can act on the world around them to maintain their arousal level, and so they maintain their arousal level by acts on themselves. As well as the potential for this to be harming, injurious, it also poses problems for us as teachers or therapists, because it is hard for us to provide anything that is as immediate and stimulating as, for example, banging your head or poking your eye. So I would argue that one of the most important things we can do for children and adults with profound intellectual disability is to give them experience of intentionality. Of course, they are at greater risk of not developing it for several reasons. So, as a baby lying in a cot and kicking their legs, visual impairment means they may not see the mobile move up and down. Hearing loss would mean they didn't hear those yellow plastic ducks on the pushchair rattling. If they have motor impairments, their movements may be reflex and not under voluntary control. Their epilepsy may mean that memory traces are not well laid down, and they don't make that ongoing link between actions and consequences. So I would regard this as the most important step that we can give children and adults with profound ID as they progress towards, we hope, some form of augmentative communication. Because intentionality, the realization that you can make things happen, is also a step towards intentional communication, which is the realization that you can use other people to bring about some kind of event or change or action. In other words, intentional communication is using the other person indirectly to get something you want to have happen. So in going back to our development chart, by around 8 months, our infant has achieved intentional communication. And this has come about at least partly through quite a simple shaping activity where, for example, we now have a 6 or 7 month old sitting in a high chair, and her older brother comes into the room eating a banana. And our baby looks excited, jiggles up and down in the high chair as the brother comes into the room. And you perhaps break off a little piece of the banana, and you infer from the baby's excitement that they want a piece of the banana, and you give it to the baby. Now, we don't know whether the baby did or didn't want banana, but they realize that their actions, the sounds, the movements that they make, the direction of their looking, has resulted in getting something nice. So babies learn that their actions can have an effect on other people. Around this time, babies also demonstrate socially instigated actions on objects. So not just actions that are differentiated by the object's physical properties, but by their social use. So they know that hats go on their heads, brushes are for brushing hair or teeth, and that little toy cars get pushed along the floor. Balls are for rolling or throwing, spoons are for eating with. And it's essential that the child has this understanding of the social purpose of objects if they're going to acquire vocabulary, because you have to understand what you might call the cupness of a cup in order to attach the verbal label of cup to it. You have to understand what a brush is for in order to think of it as a brush. At around the same time, 9 to 11 months, as we progress forward, babies start to use their intentional communication for a very clear purpose. They've already been using it for a little while for social interaction from 6 to 8 months. But by 9 to 11 months, they start to use their communication very clearly for regulating the behaviour of other people. So, for example, my friend's little boy, Duncan, likes to come and visit, and he's very, very interested in our family cat. So Duncan will come crawling into our kitchen, and the cat, who is not in the least bit interested in Duncan, will retreat right up to the top of our fridge freezer. And poor Duncan looks up at this cat, and he really, really wants to stroke it. So he pulls himself up to standing on the side of the fridge freezer, and he looks at the cat, and he looks at me, and he takes one hand off the fridge freezer, and he reaches up towards the cat, and he makes urgent noises. Ah, ah, ah. And the cat, of course, retreats to the furthest corner of the fridge freezer. But Duncan is clearly signalling to me, I want that, and I want you to get it for me. Now, the nice thing about initiations for behaviour regulation is that usually there is clear feedback that you've got it right. So if Duncan were looking at the table and going, and reaching for a drink, I would immediately be able to give it to him. So he's initiated using, looking, vocalizing, reaching, and he gets what he wants. A little bit more challenging, but actually much more interesting, is the initiation for joint attention. And this is where the infant at around 11 or 12 months of age doesn't want a thing. They want you to notice that something interesting has happened. They want to share an experience with you. So, for example, you come towards the baby, and the baby points down at your shoes and goes, oh, or da, and looks up at you and looks down at the shoe. So they don't want the shoe. They want you to notice that they've noticed your shoes. And what would you do as a supportive communication partner? You say, oh, new shoes, or shiny shoe, or mummy's shoe, or red shoe. And in doing that, you provide the baby with an ideal language learning environment because you've provided the verbal referent, the label, for the very thing that they're most interested in at that point. So initiation for joint attention is important for that respect, but it's more important for its role in the whole concept of communication, that communication, as well as being to get things that you want, is about sharing our humanity. It's about those moments of shared experience. And it won't surprise you then if I say that whilst initiation for behaviour regulation seems to be acquired by most or all children at the right developmental level, initiation for joint attention seems to be much more challenging for example, children with autistic spectrum conditions. Now, as we move on from 12 months, the reasons for which children use their communication expand. They start to use early semantic roles, and somewhere around 12 to 18 months, they're using first words, and that's beyond our brief for today. Now, what are the implications of this account of early development? The first one is that communication can be seen as developing through cognitive and social interactive routes, and that both of those are important. We can also see that communication develops in small steps, but can be affected by different disabilities. So, for example, motor impairment, visual impairment, autistic spectrum conditions. But I would argue that opportunities for developing along these steps can come from both social and cognitive aspects. I'm going to argue that the development of intentionality is a really significant step, and that communication partners play a very important role, and hopefully I've persuaded you on both of those points. So progress in or towards AAC is going to draw on this cognitive development, this increasing world knowledge, and also on the learner's interest in and skill in interacting with others. So I want to say something very briefly about the assessment of communication. And I'm posing a couple of questions here. If we're assessing pre-verbal communication, does the language of the assessment matter? So does it matter if it's written in Bulgarian, English, Spanish? And then we also need to consider what aspects of communication we're trying to assess. Are we looking at cognition and communication? Are we looking at comprehension or understanding? Are we looking at the learner's social use of communication? Now, most communication assessments assume that the learner's development will follow a broadly typical trajectory. And I've already hinted that that may not be true for children and adults with profound ID. And because our learners' communication can be quite idiosyncratic, a familiar person, so a parent, another caregiver, a familiar teacher, should always be involved in assessment. And a one-off assessment is unlikely to give us a good picture of the learner's development. I'm not going to spend any time on this except to draw your attention to 4 freely available assessments in English and Welsh for the first one, in a wide range of languages, including Bulgarian for the second, and in English for the third and fourth, which are relevant to this population. So those give you the links for accessing them. Now let's continue on to think about intervention strategies. I've argued that communication develops through cognitive and social routes, and so preparing for AAC likewise will require support from both angles. So for each of these, I'm going to present some practical considerations and then one approach to early intervention that is evidence-based. In terms of cognition, acquiring world knowledge, a couple of very practical issues here. One is positioning, and I apologise for my rather primitive drawing, but you'll see that we can come up with a range of positions that will help children with different types of physical challenge engage more easily with objects and the world around them. If you work with a physiotherapist, you're very lucky because they will also give you advice on optimizing the child's position for access to objects and how this might lead to enhancing their eventual access in some form of communication aid. We also need to think about how we're going to encourage the child to engage with objects and what they're going to learn. So we need to think about providing objects of different shape, texture, colour, smell, things that make sounds, things that are different temperatures, shapes, sizes, symmetry, moving parts, and for different functions. I've stressed the importance of contingency awareness and intentionality, and there is good evidence that cause and effect activities can teach learners that their actions have consequences, can teach intentionality. And more than that, a study by Raab has shown us that in children with disabilities, this learning is pleasurable. Children enjoy the experience of learning to be effective in the world. There are many different ways that you can gain this experience, but again, there's a whole body of research by Lancioni and colleagues and a review by Roche, which shows us that children can learn intentionality. But these opportunities to affect and control the environment don't necessarily require expensive equipment. There are many no-tech experiences that give learners the much-needed feedback on their own actions. So activities like playing with water or other responsive media give very immediate feedback. Making a mobile move, hitting a drum or a gong or scrabbling with your fingers on the surface of a drum, hitting a bobo doll. I don't know what these are called in Bulgarian, but they're dolls that are weighted at the base. So when you push them, they come back towards you. When you pull them towards you, they swing back away. There are also mainstream technologies that offer experience of environmental control. So keyboards or piano keyboard apps on a tablet. Sensory Lightbox app on a tablet, which starts with cause and effect but moves on in small steps to slightly more significant behaviour. And you can see Sensory Lightbox app working on those two links. There is, of course, specialist technology with microswitch controlled toys. There's the Big Mac to provide single message output. But these are, we have to recognise, not cheap. Moving on from cognitive to social development, there are also some practical considerations. We know from quite a body of research that contingent, responsive, sensitive communication partners enhance the quality of life for people, children and adults with profound ID, and that these interactions provide real enjoyment for all communication partners. But I can always hear some of you saying, it's all very well, but we don't have time. We don't have time for individual, sensitive, contingent interactions. One way of dealing with that might be to timetable it. So we could say we're going to give a learner experience of sensitive contingent interactions on Thursdays at 2 o'clock and Mondays at 11. But maybe it would be better if we responded in a spontaneous way. So can we integrate these kind of interaction opportunities into our everyday routines? And the answer is yes, but it's not easy. So in Samuel's study, staff in residential services didn't always find it easy to incorporate this into their everyday working practice. So how can we make time for learner-led interactions, spontaneous interactions? And I think we have to remember that it doesn't have to be a paid professional member of staff who is the communication partner. We know that parents and siblings in particular, are skilled communication partners for people with profound ID. Teachers, therapists, and other staff, of course. But what about students or interns on placement or wanting experience with this client group? How about volunteers, community members, retired professionals, all of whom might be available to provide experience of lovely, supportive, enjoyable, contingent interactions. But peers themselves with profound ID can do this. Kamstra's study showed that, sadly, we often position people too far apart in residential services to engage. But if you carefully position people with profound ID closer to each other, they too can provide interactions between themselves. Two approaches I've put on the reference list, but I'm going to focus on intensive interaction because there is evidence of effectiveness. Intensive interaction was developed by teachers working in residential provision, and it's based on the highly responsive, individualised interactions between babies and their caregivers. And it aims to promote social communication, enjoyment of interactions, and to enhance the learner's sense of agency. And interestingly, when staff are trained in intensive interaction, they appear to be more responsive to learners outside the sessions as well as in planned or programmed activities. And intensive interaction focuses on the fundamentals of communication, turn-taking, shared personal space, understanding and using eye contact, facial expression, and so on. So what have we learned? I think the key take-home message is that everyone can communicate. There are several ways to assess early communication, and cognitive development and social interaction are both important for developing communication and underpinning the use of AAC. There are several strategies that take this early development of communication further in preparing for the use of AAC, but more research on their effectiveness is needed. And I've given a number of resources on the reference list which provide you with further details. So thank you, Blagodaria. I'm going to put each of the slides of references up for around 10 seconds, but they will be on the slides that you can watch subsequently.